Good afternoon, ladies and gentlemen, dear Chairman. Thanks to the organization for the kind invitation to this Interest Congress. I'm not from Padua, it's wrong what is written in the... I'm from Italy, from Treviso, General Hospital of Treviso. I'm a plastic surgeon, and what women ask to the surgeon and to the physician is to be healthy. What asked to the plastic surgeon is to have their breasts again, to reach again their femininity. So, for me, it's a pleasure to introduce this new technique with the save of the pectoralis major. I'm not financially interested in what I'm going to tell you this afternoon. And why to search a new technique for breast reconstruction? As you know, traditional implants includes also one-step reconstruction with ADM, traditional one-step reconstruction with ABM, has still today some problems like capsular contractures, results not always natural, pain, and functional deficit. The reconstruction with free flaps or the reconstruction with flaps has until now some problems. They are more invasive procedures. They need a learning curve and are long operation with big costs. So the ideal technique, and I think that you agree with me, is a minimally invasive surgery with less pain, simple, fast, with no breast animation in the future, and without complications, if possible, like capsular contractures, for instance. When we think about something natural, we think about something that respects what is the anatomy. And in the anatomy, the breast stays above the muscle. So we thought to make a reconstruction leaving the muscle where naturally is, and making a breast reconstruction above its anatomical plane. All of you know how it's important in the fascia of the shoulder the use of pectoralis major. So to have in future less capsular contracture, we thought to interpose a more biocompatibility material between prosthesis and body. And this is what we have done, and what we have learned to this article in the 2009, when with alloderm use, the authors shown us that they had less capsular contracture using alloderm wrapping around the implants. So, to make it possible, what we need a support in order to stabilize the prosthesis to the correct position. And also, we need a protection or integration to reduce or modulate the formation of capsular prosthesis capsula. So they are more or less the same fashion that naturally does the muscle, the pectoralis muscle does. How can we achieve this? To achieve this, we have to talk with the collaboration of engineer of Decomed and a new shape to wrap around with a ADM the prosthesis. If we think about ideal ADM, we think that ideal ADM has to have a fast integration, minimal inflammatory response, easy malleability, and high strength. To reach this, we have thought about a ADM prosthetic without chemicals, using a deantigenation enzymatic. Don't use X-ray for sterilizing this material, but ethylene oxide. and ADM no thicker but 0.6 millimeter to have a less inflammatory reaction. And the ADM completely natural, without preservative, and delivered dry. Our work was born in November 2012 from me and Dr. Simon Cotton, that perhaps some of you knows. He comes from Bristol. He's an excellent breast surgeon and is a friend of mine, of course. Together, we started with this experience. This is one of the first videos. As you can see, the technique. So first of all, it is very important to put the stitches to make a new pocket. And in this new pocket, we put the implant. After this, we close the pocket. And we put the new implant wrapped with ADM after mastectomy. It's very important to put this kind of stitches, but we'll see again later. And another important thing is to make a perfect alignation of the skin. Okay, this is finished. In the next 2 years, we had the confirmation that we was in the right direction. And this work confirm our ideas. It is another word in the rats. So coming back to the technical details, it's very important that the general surgeon that makes the mastectomy is to be careful to respect the subcutaneous fat and the skin also. So it's important at the end removal of the margins of the wound before closing to have a perfect closure. The importance of an accurate suture to avoid rupture during the introduction of the ADM and the closing. At the beginning, we started with betadine, and nowadays we don't use betadine because we have seen a reduction of capsular contraction don't using betadine. And for the plastic surgeons, our results change when we start to think ADM as a skin graft. So it's very important that you have a fast integration between the tissue of the patient and the ADM. So not safe on the anchorage point of the muscle and the subcutaneous tissues. It's very, very important according to us. In the respect of the idea of one-step breast reconstruction, we always perform the contralateral symmetrization if necessary in one step, of course. Drains, always. We put drains always. We put 2 drains, never 1 drains, and we leave inside no more than 2 weeks. And if we see a seroma later, we make aspiration under control of ecography control, of course. Always bra and drugs. We put the drugs in the second day, and we suggest to the patient don't move the arm until 10 days, and they use always antibiotics when the patient go home. We have made 2 studies. One is just published and was of 25 implants, and there is another multi-center studies that includes 81 implants. This is the first original article of 1 year ago. And this is the multicentric European study that we have shown in Barcelona last March. And if you have a look of this speech, we can see that at the beginning, with the ADM more thick, we have had more problem. Later, we have changed the thickness of ADM, and we have changed also the kind to preserve the ADM, and we have had less complication. And on the left side, we can see the results and the complication of the second study, the multicentric study, and how you can see we have had a less important reduction of complications. So let me show you some clinical case. This is a bilateral Braxton, and in 1 month, so in follow-up very short. This is another after 1 month. This is of another colleague of mine from Dr. Berna from Verona, is 1 month also. This is courtesy from Simon after 4 months. I go speed. After 12 months, another patient. And after 60 months, the patient, we always perform the contralateral reduction if it's necessary. And after 2 years, you can see that the prosthesis is still soft, without pain, of course. This is the same patient after 3 months and after 2 years. Let me go. Another patient. Also, when the people move the arms, you have not dancing breast because is not connected to the muscle, of course. So this is the advantage. A case of dancing breast treated with this kind of technique, not from me, from Simon, and dancing breast is a problem with the traditional reconstruction because of the capsular contraction that link the soft tissues and bring together with the prosthesis. So this is a film. How you can see is after 2 years, I see that it's impossible to see the difference between the right that made the surgery. Okay. So the conclusion, advances over traditional one-step prosthesis technique for the patient, according to us, natural results, less post-operative pain, omeloscapular rhythm conserved, no physiotherapy is necessary, less percent until now, we have a follow-up for 3 years. It's not a lot, but it's enough. And 1 step, 1 surgery. For the surgeon, is faster, is not very difficult. We can perform our poker during the general surgeon makes the mastectomy. Reduction post-operative complication, reduction incidence of capsular contracture until now, of course. For the welfare, 1 hour in less room, no expander, no long hospitalization, no physiotherapy necessary. But is not a technique for all the patient. The ideal patient have a candidate to skin or nipple sparing mastectomy, medium-sized breast, moderate breast ptosis, trophy skin and inframammary fold, trophism, no radiotherapy, and no big smokers, of course. And we need a learning curve. In some cases, we have until now implant visibility, a poor upper pole, you can see, and in this condition, lipofilling is advisable. In conclusions, after 30 months and more of experience, our patients were respected. The technique seems safe, reliable, and reproducible. The follow-up, also more than 24 months, is still insufficient to draw the definite conclusion. Further work will confirm the validity of this new reconstruction technique. Thank you very much for your attention.
Thank you very much, Dr. Atta. The next speaker is Pico will be Professor Wimsar. Professor Wimsar will talk about our experience with autologous bone marrow therapy during MRM to prevent flap complications. Yes.